talk?
Dr. Deepthi Vaidya.
Yeah. Do you have that talk?
Yes, I'm having the recording now.
Okay, then we will start. Okay. So Dr. Prachi, you can start.
Thank you, ma'am. Good evening, everyone. Good evening, eminent guest speakers and faculty members. A warm welcome on behalf of Shield Healthcare. I'm Dr. Prachi from Shield. Welcome everyone on today's webinar. It's about instrumental delivery and Caesarean section. It is my pleasure to introduce Master of Ceremony, Dr. Sunita Khedkar ma'am. Ma'am is consultant and director of Khedkar Maternity Hospital since 14 years. She was ex-registrar at Wadia Maternity Hospital, Mumbai, and ex-consultant at MIT Multispeciality Hospital, Aurangabad. Ma'am's special interests are sonography, infertility, and menopausal health. So with this short introduction, I'm handing over this session to Dr. Sunita Khedkar ma'am. Ma'am, over to you and warm welcome. Thank you very much.
Thank you for the kind words. I would like to welcome all for this today's webinar. Firstly, I'll welcome Dr. Varsha Baste ma'am. Can we have ma'am's CV? Madam is practicing gynecologist and infertility specialist in Nashik since last 30 years. She is director of Baste Maternity Hospital and Pushpa Fertility Center. First ICSI and PGD baby in North Maharashtra in 2003. Past president of Nashik OBGY Society. Chairperson of Foxy IAEC 2019 to 22. Prestigious Anandibai Joshi Awardee. Amongst B for Sri Puraskar by Honorary Governor of Maharashtra. Foxy Champions of Foxy Award. Foxy Excellence Award for outgoing Foxy Chairperson. She has organized many national as well as international conferences, participated in numerous national as well as international conferences, founder member of MSR Maharashtra ISAR, life member of IAG, fellow of ICOG and FICOG, diploma in infertility at Kiel University, Germany. Welcome, Varsha ma'am. I'll request Varsha ma'am to kindly invite today's guests of honor and chief guest.
Good evening, everybody. I welcome you all wholeheartedly, and I'm very much excited because of this Maharashtra very, very important webinar, which is a must for each obstetrician to tackle with labor emergency. So we thought, why not to have the subject which is very, very needed for practicing day-to-day Foxian, and which will give them everybody the updates of how to tackle the labor emergencies. So for this webinar, Dr. Pardeshi, our chief guest, Dr. Rajendra Singh Pardeshi, who is the president of AMOGS, and he's such a gentleman. He never says no, always encouraging. And I'm really honored, Dr. Pardeshi sir, for accepting the invitation and gracing the occasion and increasing the standard of this webinar just by your mere presence. So let me introduce Dr. Pardeshi sir. He has presented 28 papers, 7 times best paper awardee in Foxy ICOG conference, was faculty in AOCOG in Taipei, Bangkok, faculty FIGO in Kuala Lumpur and Rome, was chairperson of Food and Drug Committee, awarded Dr. Hansutia Best Committee Award, great, and was vice president Foxy 2019-20. And 21 was vice president AMOGS in 2018-22, and now president of AMOGS 2022 to 24. So with this brief introduction, can I introduce Dr. Pardeshi sir? Sir, we are really blessed to have you here, and we would like you to address the gathering.
Thank you, Dr. Varsha, for kind introduction. Thank you so much. Good evening, everybody. Respected Dr. Mandakini Meg ma'am, our grandma, Dr. MC Patel, Dr. Sujata Dalvi, Dr. Kishore Apnurkar, and our AMOGS office bearers, Dr. Sudesh Doshi and Dr. Sunita Khedkar. Really happy to address this webinar on instrumental delivery and cesarean section. Dr. Varsha has chosen really nice topics because these two topics are related to each other. Now government has requested us to reduce cesarean section rate, which is now up to 39%. We told them, no doubt, maternal mortality has been reduced by 44%. That is our MMR. That was 556 per lakhs in 1990, and now it is 97 of India. But we told them, proudly we told them, we are proud of Maharashtra and our AMOGS members, that our Maharashtra MMR is 37 only. And this is because of all our AMOGsians, and we are proud of that. And credit goes to all our AMOGS members. Still, we can reduce this 39% of cesarean section rate further. And that's why this webinar is very important, because instrumental deliveries, they are very important. I appeal to everybody to take this task of reducing cesarean section rate. Of course, this initiative taken by Dr. Varsha Baste and team is highly appreciable. As with the art of instrumental delivery, we can reduce cesarean section rate also. But the difficulty is not of instruments. Many people, no, forceps, we don't want to apply forceps, vacuums, no. So the instruments are quite difficult. It's not the difficulty in instruments, but the operator are not trained. It's a difficulty in operator. And we can't blame on operator also, as they are not trained enough nowadays. And this will be, otherwise, this art will be dying art. Because nowadays, instrumental delivery has been really reduced. When we were residents, our seniors used to stay with in each and every procedure of instrumental delivery. I appeal to all the teachers present here that, and they should teach all the residents, not only residents, but the practitioners also, this art of instrumental delivery. In this regard, this webinar is covering almost all parts, all of instrumental delivery and cesarean section, and with difficult cases also. It's really a best practical webinar with a galaxy of speakers like Dr. Dipti Vaidya, Dr. Swati Badgire, Dr. MC Patel sir, Dr. Varsha Baste, Dr. Kalyan Baramde, and all panelists. I think this will be a great event. I wish every success to Dr. Mandakini ma'am, our grandma, for our future endeavor in Foxy accident. I wish every success to Dr. Varsha Baste for our future endeavor in Foxy accident. Our best wishes, Dr. Varsha.
Dhanyavad.
Wishing success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, Dr. Pardesi.
Thank you, sir, for your blessings and nice words.
Yes. Over to Dr. Sunita.
Okay, thank you, sir, for your blessings. Now I would like to invite our guest of honor, Dr. Mandakini Meg ma'am. Madam is chairperson of ICOG Foxy 2020-21, International Vice President of MWIA Central Asia, Vice President of AMWI Central Council, National Vice President Foxy 2012-13, Past President of Indian Federation of Ultrasound in Medicine and Biology, Past Dean of Indian College of Medical Ultrasound, Chairperson. Okay, welcome, ma'am.
Everybody can read now. Good evening, everyone.
Our next speaker, our next guest of honor, Dr. Apnurkar, could not join because he's unwell. He just called me. He's having viral fever, so he's not there. So Dr. Sujata Dalvi will be shortly joining. So I request Dr. Mandakini Meg madam to give the pearls of wisdom that she's so much famous. Such a nice, loving, caring, and good advisor, great friend in her I have found, and great advisor. She's so supportive, and I really love you, madam, because of your generosity and so much of accommodating nature, and so much helpful. You have done wonderful job, wonderful work in Foxy, and you have been doing it since long that everybody appreciates you. So I welcome you, and I request you to give your pearls of wisdom to the gathering.
Good evening, everyone. At the outset, I'd like to thank Dr. Pardesi for being the chief guest for our AMOGS conference, Dr. Varsha Baste, Dr. Sudesh Doshi, all the office bearers of the AMOGS, Sujata Darvi, and other guests of honor, and all the contestants. I think Dr. Pardesi, I agree with Dr. Pardesi, the subject chosen by Varsha is very, very apt, because the increasing rate of cesarean section, as the head of Maharashtra Dr. Parde is saying that we are getting letters. I think Archana Patil's classmate was there. We were getting letters after letter. Please give your cesarean section in your institute. So much of pressure for the private practitioner. Also in the Foxy office, Jaideep Tank always shows my slide also. Along with him, I was going to the Maharashtra government and formulating how to report. There was a LQ also in Maharashtra, how to report the cesarean section rate. So for the time being, I want to inform everyone here that for the time being, we asked for the time and said that we are going to, formalize the Tropson's criteria. We will take a meeting, and after the total, decision which has been taken by the managing committee, everybody will opine, and then we will come back with a proper rate, because they should not, what I'm trying to say, just compare the 10 to 15% 1985 rate to the present rate, because we know so much of indications, everything is increased. I don't want to take that time in my guest of honor, but it is increased, and there are various reasons. Second reason, which is connected with the increased cesarean section rate, is a lack of instrumental delivery. Dr. Pardesi said very correctly, because lack of operating person. So when we think that we are supposed to give advice to how to reduce the cesarean section rate, training in the instrumental delivery comes the first in the medical colleges, and
Yes.
also, and it's not only the hard and those horrible instruments. They are very sophisticated. Piles forceps are there, small forceps. The other day I saw beautiful forceps, just giving a little, in the heart disease cases, just to give a push. They're beautiful. So everybody is now convinced that we should train our juniors, train our people to do the more instrumental deliveries. And I think with this webinar, we are having many people who are now, talking of the instrumental delivery. They are going to talk on the latest cups and all, and modern obstetrics with the modern this forceps and the pulling instrument which is there. So I think with this, I would like to just conclude by saying that it is our moral responsibility to reduce the cesarean section rate, because like hysterectomy, we are going to be on the target of government sometime or the other, and cesarean section is a very important surgery which all of us do. That is one thing. And second thing is moral responsibility of our own self, that we should teach our juniors how to do the instrumental delivery. These two important messages I wanted to give. And also the third important message, to congratulate all of us, which Dr. Pardesi has already said, that maternal mortality has come down to the number. We are number 2 in the country. I think I was invited by Paili sir to give a Maharashtra experience, and also in the Ahmedabad. And we gave them some beautiful policies, very cooperative obstetrician, private practitioner doing everything free of charge for the government. With all these policies and so many MOX policies also nowadays, I can see so much. Dr. Pardesi has given that wonderful address of president, and there was a standing ovation. So there are so many things he's coordinating with the government. I'm really heads up to you, Dr. Pardesi, for those very practical tips to everybody. So I think MOX, we are at Maharashtra, and Maharashtra government also, I want to take a little bit of credit, because I was a deputy director and we had wonderful relations in that. So we go hand in hand. The most important example of government and public is a Laksha Manyata, because there was a Laksha. We brought the Manyata, and only Maharashtra is there. We combined the Laksha Manyata, and we were again given the second prize in India for this Laksha target and Manyata. So with these words, very motivating, message for all of us to keep on doing the good work and bring our MOX Maharashtra on the forefront by reducing further the maternal mortality and morbidity. So thank you very much for invitation, Varsha, and I hope it served the purpose. Thank you.
Thank you, ma'am, for the words of wisdom. Now I'd like to invite Dr. Sudesh Doshi, sir, convener. Sir is senior obstetrician and gynecologist, working since last 25 years in rural setup at Pandharpur. He has experience of delivering over 15,000 babies at his nursing home, chairperson of Adolescent Health Committee in 2016-18, chairperson of Medical Legal Committee, AMOX. He is member of PCPNDT, Foxy, past president of Pandharpur OBGY Society, past president of IMLEA Maharashtra chapter, member of EMLC Foxy, zonal coordinator of AMOX. Welcome, sir. With this, we can start with our academic session. To chair the session, I'd like to invite Dr. Uma Soni ma'am and Lalita Swami ma'am.
And before that, let me welcome all the faculties, dear Sunita. I want to thank Dr. Pardeshi sir and Dr. Mandakini Mek madam. Dr. Sujata Dalvi rang me up. She's joining shortly, I think. Dr. Adnukar sir is not well, so he couldn't join. He called me. And I just want to welcome everybody. Each of you have spared your important time to give the successful updates for this important webinar. Convener Dr. Sudesh Doshi is always cheerful and gives lots of information in short time. And our smart MOC, thank you Sunita Kedkar for being the MOC. So you are so active. The speaker, Dr. Dipti Vaidya, couldn't join, but she has sent her this recorded version. So we will play that. And for the chairpersons, Uma Soni and Lalita Swami, I welcome them. And for difficult cesarean section, the speaker is Swati Bhatgiri. She was the first one to join, and the chairpersons are Oswal sir and Vaishali Datal. Both of them are so active. Vaishali from Latur and Dr. Vinod Oswal from Bid. And they, I know them from since ages, I think, but they are really great stars of AMOX. And the third talk will be about legal issues in difficult caesar section. The Dr. MC Patel, who else will give us guidance about how to tackle legally for this difficult caesarean cases if anything occurs. And to chair his session, we have Dr. Prasad Magar and Dr. Krishna Pawar sir. So they are also so well known personalities of Maharashtra. And the panel discussion will be moderated by me and none other than Kalyan Barmade, our Joint Secretary of IAG, and such a nice, very humble and very helpful person. The panel is esteemed panelists. I really am wonderful, feeling wonderful because we have plethora of these people, esteemed panelists like Vaishali Surje from Aurangabad, Smita Kulkarni, and the infertility specialist from Jalna. Then Anil Kayande from Linka and from Amravati, then Rachna Jaju, she has made wonderful impact during AMOG's Aurangabad. Anuradha Garad, who is the past president of Usmanabad, and Purnima Yende from Bid. So I really am thankful to all of you for being here and giving your updates and giving the knowledge which is needed for day-to-day Foxians, how to tackle with obstetric emergencies. I'm really thankful from the bottom of my heart. From the very beginning, I really welcome you all and thankful for your presence here. Over to you, Sunita.
Thank you, ma'am, for your overview and guidance. I'd like to invite our chairperson to grace the first session, Dr. Uma Soni, ma'am. Ma'am, it's past president of...
Can we do one thing? Let Dr. Sudesh Doshi sir also give some his... and I let him address the crowd.
Yes, welcome Sudesh Doshi sir.
Dr. Sudesh Doshi sir, please address the audience. Sir, you are unmute yourself. You are not audible, sir.
I think he must be busy. Sudesh Doshi sir.
Cannot connect you. We can see your video, but you are not audible. So can you leave the meeting and rejoin? Okay, continue. Sunita, you can take over.
Okay. We'll start with the first session, which is lecture by Dr. Dipti Vaidya. To chair the session, we'll invite Dr. Uma Soni ma'am, who is past president of Hingoli OBGY Society. Madam has undergraduate and postgraduate from Ambejogai College. She has worked as assistant lecturer at MIMSR College, Latur. She has 4 years of experience as assistant lecturer at PMT Pravara Medical Trust. Welcome, ma'am. Our second chairperson is Dr. Lalita Swami. She is consultant obstetrician and gynecologist at Swami Hospital, Usmanabad, ex-medical officer at Women's Hospital, Usmanabad. She has 18 years of experience. We welcome both the chairpersons. I'll request chairperson to kindly introduce our speaker, Dr. Dipti Vaidya.
Hello.
Yes, ma'am, you're audible.
Good evening, everybody. First, I will
Yes,
thank
madam.
the organizer for arranging and giving opportunity for this. Today we have a talk on this important topic as a instrumental delivery by Dr. Dipti Vaidya madam. Dr. Dipti Vaidya madam, MD OBGY, fellow in IVF endoscopy, ex-consultant Global Hospital Baroda, ex-lecturer MGM College Aurangabad, consultant Anand Hospital and Bijampur IVF Center. She has experience of 13 years. Faculty MRCOG and local and state level conference. So I would request, madam, please start the session. Hello.
Sahitya Priya.
Yes, ma'am.
Hello, good evening, everyone. I'm Dr. Deepthi Vaidya, and I want to thank the organizing team for having me for this talk today. Today, I'll be discussing on instrumental delivery. As far as instrumental delivery in today's practice is concerned, we only limiting ourselves more and more by not using it, may it be forceps or a vacuum delivery. The decreasing incidence of instrumental delivery, which has gone down to almost 2% from a whooping 25%, itself shows that obstetrical practice these days is more oriented to how we can ensure a good Apgar, plus keeping ourselves safe and avoiding maternal and or neonatal morbidity. Out of the fear of litigation and to a lot of extent lack of training and the ease of opting for cesarean section globally, we have seen that this trend is going down day by day. And with the evolution of new techniques of anesthesia and safer and easier cesarean, the use of vacuum as well as forceps has gone down. So when do we actually use vacuum either for a maternal or a fetal indication? The rotational to outlet forceps is another evolution that has happened, and slowly now we have the single blade application of forceps. Also, we limit ourselves to using vacuum as well as forceps only in case of a difficult cesarean or in dire emergency where we have a stuck head at the perineum and the mother is exhausted, and it is better that we opt these because the time taken to section as where it comes to a difficult vaginal delivery versus a difficult cesarean section. So what if there is a difficulty in a cesarean baby delivery, or what if there is a catch where you have time and you are more in need of saving a good Apgar compared to opting for which type of delivery? In these cases, these days we only have these two limited indications where we wholeheartedly would opt for an instrumental delivery. So where do we stand in the current use? The role of vacuum delivery only per se where we have a floating head in cesarean. There are also a lot of people use techniques on their own which would avoid instrumentation. The flaw of vacuum these days lies in the time taken to deliver the fetal head. The chignon that is formed is not acceptable to many patients because they want a perfection with their child coming out. And when we try to take an elective consent, this becomes an obstruction getting a good consent for a ventouse. There is no advantage in fetal indication as far as the fetal distress is concerned when we have a vacuum or a ventouse delivery. It is better because the maternal trauma in a ventouse delivery is less. And it restricts its role more in LSCS, that is elective maternal indication in vaginal delivery. So the role of vacuum has a very limited options of application where we have a shortening, a second stage, or a floating, high floating head, or a second stage vaginal trial in an unrotated hair, where itself we would hesitate to apply forceps. Similarly, forceps delivery is more out of repute these days because we are not sure whether the application would be correct. We don't want any fetal injury because there is more and more litigation these days. So we limit ourselves to more kind of vacuum, but the greatest disadvantage of vacuum sometimes the conditions that we apply being the time taken to deliver, and hence most of the obstetrician opt for an emergency cesarean section versus these two. But the compromise we end up is fetal Apgar. So the forceps delivery still restricts it to a shortening second stage, especially where it is a difficult cesarean as far as giving anesthesia risk is concerned. Shortening second stage electively, fetal distress where we get in second stage, or a difficult fetal head delivery in cesarean section. So then do we really need to use this, or are we going to make them history? Well, evidence says that vacuum is more mother friendly, so it saves the care of the doctor. And it's not for the preterm baby. This is the biggest disadvantage that vacuum offers where forceps takes over. It is not for a distressing child simply because when we take evidence and we counter it with litigation, it favors more role of forceps. However, these need good counseling for fetal signon or, for example, the maternal or fetal minor minuscule complications that even if in good hand may occur once in a while occasionally. So even though harmless, we need to counsel properly and anticipate its use. Now we come to what are the advantages. Why should we consider vacuum and forceps not disrepute still now? Because more and more that we opt for cesarean, more and more we are going to lose manipulative vaginal delivery. We consider vacuum delivery still where it decreases the space and volume of the fetal head to deliver. This is especially where we have a second stage, slightly non-rotated head, which is deflexed, where the mother is getting exhausted. And the time taken here to decide and deliver by a cesarean versus expediting the delivery by instrumentation would help both the mother and the fetus. So here vacuum plays a good role because if we anticipate fast, we don't let caput form, and that is where vacuum can be easily applied and it would decrease the space and volume, especially when there is a lot of edema in sometimes in these cases. And it would also not give a good space for the forceps blade to get applied. So keeping both the mother, the doctor and the baby all in good position, we can have vacuum delivery in this condition. Also, for a floating fetal head, where in cesarean, we know that sometimes the head tends to dislodge and keep moving away, where there's a lot of liquor with the floating head. It would take time for the fetal head to come out. In that case, a safe vacuum application would do good. Since the space needed by this instrument is very less, and so the maternal and or fetal trauma is less also, it decreases the fundal pressure that is needed to deliver the baby. This is a single blade forceps, which is a very easy instrumentation to be done. Maximum times where we restrict ourselves to use of forceps is because there are two blades, we need to lock them properly. We need to make sure they're not applied around the fetal eye or places where we can get any neonatal injury. Plus, sometimes in a slightly non-rotated head, the application and the locking of the blade goes haywire. So this is the time where we apply and the mother is not very cooperative. We are bothered about the fetal Apgar in such kind of a crux situation. Instead of getting a manual error, it is better to use such kinds of blade where not too much of hassle is there. We simply apply and the direction becomes easy. Lot of times straight OP, that's persistent posterior phase 2 pubes is missed, and the direction of force application is also not very anticipated, and hence there is a scare that the application has gone wrong. So in such cases, the single blade would help a lot. Also in cesarean, where we have a floating head and we really don't know whether it would, it is like always scooping the head out. So this blade is taking over currently and making the forceps application for obstetricians very easy and very safe, where more and more trials and more rescue vaginals can be taken, and the rate of cesarean can be dropped safely for both the patient and the doctor. So what are the advantages of forceps? A single blade forceps is much easier simply because all the points of the rotation, the angle, you just simply need to put it around the occiput, or in case it is around the mandibular end, still it manages to get attraction over the head. Its major advantages in preterm deliveries. Sometimes there is, a borderline pelvis where the baby is small and we feel that it would come out, it gets stuck on the second stage and then we don't know what to do. So here, vacuum falls short, and such places single blade application of forceps is very easy. Intra LSTS for floating head, again the single blade forceps is very easy for those who are very well very well comfortably with applying 2 blades of forceps. Of course, they can choose whatever is convenient to them. The trick only is the time to deliver should be short, the fetal distress should be minimized, and the caput should be bypassed. In these 3 conditions, forceps takes place over vacuum. What does evidence say? Well, there are few studies. There is a Thai study. There is a study in Japan also, where they have showed that intra-LSTS delivery of fetal head by single blade forceps over manual delivery is much better at times where there is a hassle with the manual delivery. They have studied about 400-500 patients where they have compared both ways. Marginal fetal injury, rest time to deliver, uterine extension, hemorrhage, Apgar, scoring, everything is at par. The time to taken is more in manual method. Of course, fundal pressure application also is more versus very limited or less when you are using a single blade forceps. Now, mind you, where I'm talking about the single blade forceps, but I'm very sure that people who are commonly using a double blade application as we routinely used to do for Wrigley's or an outlet forceps, they would still find an outlet forceps more comfortable, and that's perfectly fine. This is with respect to decreasing trend of the instrumental vaginal delivery over making our life simpler and easier. The Thai study on 101 women where elective Caesarean forceps delivery versus a manual head delivery was tried, and the percentage of babies with the Apgar, the time taken to deliver, maternal complication, intrasection as well as otherwise, etc. were analyzed, and we found that there was no significant difference between the amount of complication except the time to deliver head, shorter in forceps delivery, and a slight increase in incidence of fetal injury in terms of marks, not more than that. Rest all results were the same. So if we take evidence, then there is nothing for us to fear. If we master the technique of perfect application of these 2 things, then we can easy our job. Where does vacuum stand in this? Where ventouse is the same, where we compare during LSTS. For delivering the fetal head, it decreases. Also, Chignon is noticeable, but rest all fetal as well as maternal complications are not to a great extent very statistically significant. So that also gives us a very good way of keeping both the mother and the child safe. So now who's better, forceps or vacuum? Well, as they say, every usage of every instrumentation has its own place and it has its own speciality where it takes over the other, and we cannot distribute that at any point. So as long as the user decides the fetal and the maternal outcome being good, and stats wise the forceps fares better, technique wise the vacuum being easier, but of course single blade forceps makes it even easier for as far as forceps application is concerned. Single blades fare superlative option in terms where vacuums are not usable. So how is it simple? Because the technique of application is very easy. The flexion point of application, like we have to see in vacuum. Similarly, the blade application and the locking and the way we introduce it, there shouldn't be any hassle while introduction because we're scared of vaginal tears or extensions. That being very easy because just one blade to put. And if we get good enough space around the head and the pelvis, then that job is done. All the advantages of forceps with the single blade are still there as the double blade is there, plus the ease of application and low chance of complication. Also, when we're applying single blade, very noticeable thing is the direction of traction need not be changed because the blade itself is angled at a right angle. So once it hinges properly on the fetal head, we are very sure that the application, if made correctly, is going to deliver. The key to a good obstetrical practice is an advanced anticipation and planning. These days, because we need to get a very good consent from patients, it's difficult when we need to change our decision at an emergency moment. So if we plan and anticipate properly, then we get time enough to counsel the patient as well as get their consent and then free our heads and applying whatever we feel is the most suitable at a given amount of time to keep the fetal and the maternal condition good. Now, as we know that the incision to delivery interval of less than 8 minutes and the incision to delivery interval of more than 3 minutes should be avoided because we have fetal, sorry, fetal results being seen getting jeopardized, sometimes minuscule. So early intervention in vaginal delivery should be definitely made because that will keep our life easy, because we will get ample room to choose between vacuum as well as forceps. If we delay our decision to apply, then we would obviously rule out vacuum because the caput edema starts coming in, and then the failed vacuum will set in if we don't apply it at a correct time. So SOPs on these should be clearly defined in each and everyone's setting in wherever. Plus, considering what are our personal limitations as well as advantages in using the instrumentation that we have, so that we can give the best results. That is what matters in the end. Whether we use a single blade or a double blade or a ventouse, what matters in the end is how we have conducted and how smoothly we have anticipated as well as conducted, keeping the patient's head not getting jittery, as well as obviously our own. So what's different in a single blade? As I said, the lower blade of forceps is inserted first and then the upper blade if needed. We can also use a single blade Wrigley's forceps in case someone doesn't have it, or there is room to apply. I've already tried it in a few. It's especially in outlet situations of fetal station only, and it is very easy. Especially it is very, very advantageous in preterm, where I told you that there is a minuscule lag, and considering preterm, we are hesitant to take a cesarean, or we have less time because the preterm baby doesn't allow too much compromise to set in before they show results of lower upguard. So there, traction needed also is very less. Application is very, very easy. We don't need too much frontal pressure. Only if the baby weight is more, sometimes it's needed. But there we can apply the second blade and do our job very easily. Here also the direction is the same. Only thing, the first pull, if it juts in properly around the mandible, I'm talking about the Wrigley's forceps when we are using only one blade. This is for non-rotated heads where both the blades will not lock. Sometimes the head doesn't come in AP diameter as the sagittal suture as we want it to, and it gets stuck and the progress is slowed down. Here, if you don't have the single blade, the one that I showed, we can use the Wrigley's and still make sure. We just need to see that we go more towards the occiput, and once it gets locked near the occiput, the head will be very easily pulled down, and we can use it without any complications. So no need to lock the second blade, and because the direction changes a bit, we are scared because it goes little bit towards the eyebrow and the eye. So in such conditions, a single blade does a very good job. So the take-home message that we have is we need to make friends with the instrumentation in the delivery of the child and adopt ourselves and choose easy techniques which we feel are comfortable and which we can conduct very easily, keeping both the mother and the child safe. Consider planned and anticipated action. So a very short presentation, which I think
Excellent. Very nice. Welcome, Monica. I would like second chairperson to give the concluding remarks, and then I will also add my inputs.
Lalita ma'am.
Lalita Swami, madam.
Yes. I want first to thank to the organizers for such an excellent webinar and giving we people as an opportunity. Thank you, Dr. Dipti Vaidya madam, for elaborating such a difficult topic very nicely and excellently. As instrumental delivery used for decreasing the cesarean section rate. So today instrumental delivery very important. So I again thanks to the Dipti Vaidya madam and request to start the next session.
Thank you so much. Before the MOC Sunita says something, I would like to put my inputs here. Dr. Mandakini Mek, you will also notice that we at our generation, we didn't have the luxury of anesthetics and good OTs and whatnot. So I was a medical officer in Pimpalgaon, Baswandi and Nasik, because as a PSC, I'm medical officer, and I used to conduct lots of deliveries. And mainly I used to do forceps only because anesthetist had to come to Pimpalgaon, then blood bottle, even if I had to arrange it from Nasik. So maximum in trial labor acha ho jata tha, and mainly forceps deliveries. So I didn't know why there are so many, all the problematic patients are coming to me. Later on, when I left to civil hospital Nasik, I realized retrospectively, because I was doing vaginal deliveries more with the help of instrumental delivery like forceps, more patients used to come. Madam ke paas cesarean nahi hota. But the problem was that I was not in condition of doing cesarean. I couldn't afford it also. So that was the case when we used to have 90-100 deliveries per month. I used to conduct only with 2 sisters. But it was a fun, and only instrumental deliveries like forceps helped me do my obstetric practice very well. Thank you. Thank you. Over to you, Dr. Sunita.
And one more thing I just want to add here, that when we are new, we do not know how much force to apply, what should be correct, downwards, backwards, and then upwards, the direction has to be so
It's
correct.
the practice, madam. Only the teacher, the professors and lecturers should tell they should teach the students how to do it. And that is what is needed, I think. You are absolutely right, Dr. Meg, madam.
Times I remember the one sister named Gamme. She was in Akola Women Hospital. Huge load of 11,000 deliveries. I was new. She said, "Madam, मला तुमच्या मागे उभं राहायला पाहिजे." म्हटलं कशाला? म्हणे आता तुम्ही पडून जाल. When I was pulling down, and that was such a practical thing. की म्हणे बघा मी जर उभी राहिले तर you will fall.
जोर लगा क्या आया?
No, seriously. And once she actually, I was about to fall. But बघा माझी किती गरज आहे. So there are so many things, small things which we learn. And I think it's a great experience we have done in local anesthesia. We are experts. I was in Amravati 2 days back. Local anesthesia, Caesarean section. We 4 or 5 doctors are famous in Maharashtra to do, because there was no anesthesia. So with this, we never faced any medical legal case, or because it was done with all the good intention and whatever available. So thank you very much. I think it's wonderful. So now.
Very nice talk by Vidya. Dipti. Over to you, Sunita.
Thank you, ma'am. Now we are moving to our next session, session 2. To chair the session, we'd like to invite Dr. Vinod Oswal and Dr. Vaishali Datar. Dr. Vinod Oswal is a consultant and director at Oswal Hospital, Bid. He is practicing obstetrics and gynec since last 23 years. He was honorary secretary of Bid IMA for year 2022 to 21. Welcome, sir. Our second chairperson is Dr. Vaishali Datal, ma'am. Ma'am is past president of Latur OBGY Society. She is a senior practitioner since last 20 years. Welcome, ma'am. I'll request our chairpersons to kindly introduce our next speaker, Dr. Swati Badgire.
Can I introduce Madam Dr. Ostwal speaking?
Yes, sir. Please introduce Dr. Swati Badgire, ma'am.
Good evening, all the eminent faculties and the speakers. It's a great webinar from Maharashtra webinar. And I take the opportunity of introducing Dr. Swati Badgire, who is a very experienced teacher since 5 years. She has multiple publications at national and international journals. She is a contributor in Respectful Maternity and Newborn Care booklet by Dr. S.N. Gadappa. And also, she contributes in amendments in standard operating procedures by Dr. S.N. Gadappa. She is a committee member of MTP beyond 24 weeks, committee member of Internal Quality Assurance Committee under National Assessment and Accreditation Council. She is working as a co-principal investigator in phase 3 trial of UD-Live tablet, also working as co-principal investigator in COVID in pregnancy under ICMR project. Trained many medical officers under basic emergency obstetric care, and she has received recognition from FOXI for special contribution in COVID pandemic. It's a great topic that she will be sharing with a great academic feast today. I request Madam to please continue with the topic. Thank you.
Thank you, Dr. Sir. Thank you, Dr. Vinod Oswal, sir. And thank you, Dr. Varsha Baste, ma'am, for giving me this opportunity.
Welcome, dear Dr. Swati.
Thank you, ma'am. Thank you. My slides are visible.
Dr.
ma'am?
Ostwal and Dr. Vaishali Datal are the known faces of AMOGs in Maharashtra, and I am really proud of them. Dr. Vaishali is a fitness freak, and she has contributed so much from Latur, OBGYN. Really, hats off to you, Dr. Vaishali. And also Dr. Jaju.
Good evening, ma'am. So, shall we start?
Yeah, please, Swati.
Yeah, thank you, ma'am. Now, cesarean section is commonly perceived as a very simple and safe alternative to difficult vaginal birth. However, there are situations where the delivery of the baby may be difficult. There are multiple reasons for a difficult cesarean section, like difficulty in the accessibility of the lower segment or difficulty in the fetal extraction. If the difficult cesarean section is not handled properly, it is high likely that procedure will end up in a catastrophic maternal and fetal outcome. So to avoid such disaster, it is very important to have sufficient knowledge on planning and sufficient knowledge on the anatomy, planning, and appropriate conduct of the procedure. So before going to the difficult cesarean section, these are some technical nuances that one should follow in each and every cesarean section. One should have adequate knowledge of fetal lie, presentation, station, degree of flexion, position of the occiput. One should always maintain the flexion of the fetal head during the delivery of the baby in cesarean section. The shoulder and of the body should be done with a very gentle traction, and everyone should follow the physiological cord clamping, that is delayed cord clamping and skin to skin contact in each and every cesarean section. There are studies which have proved that if the induction delivery interval of more than 8 minutes and the incision delivery interval of more than 3 minutes is there, it will result in adverse neonatal outcome. So what are the difficulties that can face during a cesarean section? There are various possible difficulties, such as difficulties in opening the abdomen after skin incision, difficulties in access to the lower uterine segment due to placenta or fibroid, difficulty in delivering the baby if the station of the fetus is too high or too low, or in cases of the transverse lie or the breech presentation, and difficulty can be encountered in twin pregnancy or conjoined also. So we will deal with these difficulties one by one. What are the difficulties encountered during the abdominal incision? The most common incision performed nowadays is the phalansteal incision, but in some cases we need the midline vertical incision. Midline vertical incision is necessary in some cases when the patient is in DIC or abruption, or if a patient presents with thrombocytopenia. In these cases, a midline vertical incision is preferred, as it is associated with the low blood loss and a rapid entry into the abdomen. And what are the various type of uterine incision? There are two types of uterine incision, as we all know, the low transverse incision and the classical cesarean section. The low transverse incision is most common, and the classical cesarean section is needed only in cases of the placenta accreta or placenta accreta or percreta. And before any uterine incision, historically the creation of the bladder flap was advocated before making any uterine incision. But more recently, randomized control trials have noted that omission of this step, that is omission of the bladder flap creation, has resulted in short-term advantages such as reduction in the operation time, then reduction in the incision delivery interval, reduced blood loss, and reduced need of post-operative analgesia. Practically speaking, adequate access to the lower uterine segment may require some dissection, but it should be restricted to very what is needed and not to be done in excess. So after the abdominal incision, this is the most common difficulty encountered during cesarean section, that is dense adhesion formation. As the cesarean section rate is now increasing, the results of these adhesions, this is the most common difficulty encountered. So in the presence of adhesion, the cesarean section and the fetal extractions are very difficult, and incision to delivery time is prolonged, and the risk of complications such as hemorrhage or bowel and bladder injuries are very common. The most important aspect of the adhesion is to try for the normal anatomy as far as possible. So you should cut and tie the rectus muscle for the better exposure of the lower uterine segment. You should clamp the if the omental adhesions are present, you should clamp the adhesions and cut and tie with the vicryl number 1. And in cases of the if you suspect the bladder adhesions, you should try to open the peritoneal cavity by cutting higher up. And in cases of bowel adhesions, the sharp dissection is needed. The next most common difficulty encountered is the delivery of the floating head during cesarean section. So why this delivery of the floating head is difficult? Because in an uncomplicated cesarean, the head is typically has advanced beyond the site of our uterine incision, and when the head is gently elevated and flexed towards the incision, uterine forces naturally push it along the path of least resistance, that is, which is through the hysterotomy incision. But by comparison, when the head is floating above the hysterotomy incision, the uterus has already accommodated to the position of the fetus. Therefore, uterine forces do not do not direct the head of the fetus through the uterine incision, and even after applying the fundal pressure, there is a tendency to push the head laterally rather than towards the hysterotomy incision. So how to deal with this floating head? Relatively safe and easy options. First one is the instrument use, like either forceps or vacuum, and second is the internal podalic version with breech extraction. The most simple and important is the instrumental use. First, we will see the use of the forceps. The purpose of the forceps is to extract the head by scooping it out from its bed. For its use, the uterine incision should be adequate. And after the it is suggested that the lower part of the uterine incision should be lower part of the head at the level of the anterior parietal prominence. Then facing the feet of the patient, the operator with the Then, facing the feet of the patient, the operator with his left hand guides the insertion towards the insertion of the posterior blade. As we can see here, after the incision of the on the uterus, the excess of liquor is allowed to drain as the head is floating. So, the right hand of the operator is inserted, and with the left hand, the posterior blade is inserted between the by gently lifting the head towards the fundus. And at the same time, with I flip the tip of the blade over and closely hugging the cranium and posterior cheek of the fetus. When it's placed, the handle should be perpendicular to the floor. In similar way, the anterior blade is applied. And here the forceps is locked and gentle traction is given, and the delivery of the head is done in these cases. As you can see here, after the locking of the blade, a gentle after the doyens is removed and a gentle traction is given. And without any extension on the uterine incision, the delivery of the head is achieved. The next vacuum assisted delivery. Awareness of the fetal head position is very important in cases of the vacuum assisted delivery. Ideally, the cup should be placed over the flexion point. Where is the flexion point is located? Flexion point is located approximately 3 cm anterior to the posterior fontanelle over the sagittal suture. It is at this point where the diameter it crosses the sagittal suture, and if traction on this point, it promotes the flexion of the fetal neck and presenting the smallest diameter through the uterine incision. So after applying the force is applied and the delivery of the baby is accomplished. Next is the Briand-Merlis extractor. A very innovative instrument was devised by Briand-Merlis in 1948 for the extraction of the fetal head during cesarean section. This instrument consists of a single fenestrated blade, which is of the shape of which is very similar to that of the ordinary forceps, except that it has a very exaggerated cephalic curve. Immediately at the base of the blade, a double hinge is built, which is of normal diameter with that of the shaft of the handle. So after the double hinge, there is a sleeve which on a simple movement covers and locks the double hinge, converting the instrument into one piece and making that instrument rigid. So we will see how the use of the vectors, that is this Briand-Merlis instrument, is done.
This is a vectis. This is used to deliver the deeply impacted head in the past. But this vectis is designed in such a way that it has got a joint here where you can move this backward and then you can lock this out. So the advantage is that you can remove any fetal head in the lower uterine segment when you are doing cesarean. So how to apply this? You have to take right palm and first put in the lower uterine segment and guide this blade on this. Once it goes below the head, then you have to just lock it. And once it locks, then you remove it. So this is the vectis, and you will see the video of this vectis during cesarean. So here we are opening the lower uterine segment, extending the incision laterally and upwards. And after that, if the head is floating, we allow the LICA to drain. And then we take the head extractor or vectis in your right palm and insert it between the lower uterine segment incision and the fetal head. So the palm is guiding and we are putting the vectis between the head and the lower uterine segment incision. And once it goes and slides down, then just lock it. There is a lock, sliding lock, it gets locked, and then just lift the head with this extractor. So the head is being lifted here, and due to this, the head is gradually coming through the incision. You have to remove the noise before this, and gradually the head is delivered. So this is a very uneventful, smooth delivery with a head extractor or vectis.
So we have seen the instrumental delivery in floating head. Now we will move to the next difficulty, that is deeply engaged head. In contrast to the floating head, deeply engaged head, it is when the fetal head descends into the vagina and it does not progress further. The vaginal tissue in cases of the deeply engaged head conforms to the head shape of the head, resulting in a negative suction-like cup that can make the elevating head back up to the hysterectomy incision very challenging. So a very well-placed uterine incision. A well-placed uterine incision, adequate uterine relaxation, slow, careful, and deliberate placement of the operator's hand around the head, and possible use of adjunctive instruments like forceps or vacuum will allow controlled or traumatic delivery of the head and will reduce the likelihood of uterine extension. So, what are the common pitfalls to avoid during delivery of the head in deeply engaged head? Making the hysterectomy incision too low. In some cases, as the head is deep, we may inadvertently incise the vagina, which may be quite challenging to repair. The appropriate area for the incision in second stage section is always higher than expected in other circumstances. Second is the common pitfall is acting too hastily and forcefully. Even in the settings of acute fetal bradycardia, taking an extra few seconds to assess any anatomy and initiate gentle maneuvers will likely not contribute to any additional fetal compromise. Generally, the surgeon has up to 5 minutes to deliver a previously well-oxygenated term infant before increased risk of asphyxial injury occurs. Third common pitfall is flexing the wrist against the lower uterine segment between the incision and cervix and using this area as fulcrum to dislodge the head can result in cervical laceration. And fourth, of course, most common pitfall is not having a plan of the delivery of the baby in deeply engaged head. So what to choose, which maneuver to choose? We have various maneuvers for the delivery of deeply engaged head like reverse breech extraction, push method, pull method, Patwardhan method, and fetal disimpacting system like fetal pillow. So which method is, we will go one by one. First is the fetal pillow. The fetal pillow, it is a fetal pillow is a variation of the fetal elevator. The disposable device has a balloon that is inserted into the vagina just below the fetal scalp when the patient is being prepared for cesarean. Prior to the cesarean delivery, the balloon is inflated with around 200 ml of saline, which is meant to gently lift the fetal head 2 to 3 centimeters from its original position. After the newborn is delivered, the device is deflated and removed. So, next instrument is the vectis. And so we here we can show we can see the use of the vectis in cases of Sorry, this is the Patwardhan method. The first, the anterior shoulder is delivered along with the anterior arm by hooking a finger within the elbow, if required, and with a gentle traction on that on the shoulder, the posterior shoulder is then removed. As you can see here, the posterior shoulder is thrown and removed by gentle traction on the first shoulder. The surgeon holds the trunk of the baby gently, gentle traction with both thumbs parallel to the spine, and fundal pressure is gentle fundal pressure is given by the assistant, and then buttocks are delivered. And lastly, the baby's head, which is then the only part still inside the uterus, is delivered. So this is a modified Patwardhan method. Next is the reverse breech method. In these cases, as you can see here, there is deeply engaged head. After the enough uterine incision is made, as you can see here, the shoulder is visible. That means head is deeply engaged. The operator hand is inserted into the uterus towards the fundus to grasp the feet, which is then pulled to footling breech extraction here. When grasping and pulling the feet, care must be taken, not pressure to be applied only in parallel to the axis of the legs to avoid fracturing of the tibia. And once the feet are then hysterectomy incision, then the delivery is accomplished as typical breech extraction. We have studied the various Caesarean trains in Caesarean section in like deeply engaged head or floating head, and we have come to the conclusion that the breech extraction, reverse breech extraction, is the most successful method in the cases of deeply engaged head, with a success rate of 90% and 2%. Only 2% is a failure rate, and least preferred the least success rate was noted in the Patwardhan method. So, there are also various studies were published in British Medical Journal, and they have came to the conclusion that reverse breech extraction is associated with significantly lower maternal risk as compared to with the push method. So, what are the difficulties during the breech delivery of the cesarean section? Abdominal delivery is no different than the vaginal breech extraction for a breech delivery. Limbs are manipulated through the natural range of movements, and trunk is supported by the pelvic girdle. And delivery of aftercoming head, you should avoid the trapping of the aftercoming head by retracting the uterus, especially in cases of the premature breech. And Maris's Melibet maneuver can be performed for the delivery of the aftercoming head, or you can also apply the forceps application. Here, the delivery of the breech during cesarean section is same. As there is a there is flex breech, means only buttocks are visible. So with the right hand of the operators, a gentle traction is given. Just elevation of the fetal buttocks is needed. In any breech delivery, the anterior back should always be anterior. And after the scapula are visible, both the arms are extracted, and lastly the head of the baby. So this will be super morbidly obese patient was reported at our institute with a weight of around 155 kg. So in India, this was the first morbidly adherent, morbidly obese patient was reported. So every effort was taken to avoid the morbidity in these patients. We operated with special precaution. We are starting from the wheelchair, stretcher to match the patient's weight. Blood pressure apparatus with large cuff was made available, and large OT was stitched specially for her. team of specialized doctors, including senior obstetrician, senior physiologist, the physician, endocrinologist, were consulted, and preoperatively, after the measurement, 2 operation tables were joined, and intraoperatively 2 extra assistants were required for the abdomen for extra fat. The baby was delivered by using the intracaesarean forceps application. And the post-operative period was uneventful. Patient was discharged on day 7 with a healthy stitches and no wound gap was noted in this case. We have also published this case. In cases of the abnormal placentation, we have to always check preoperatively the exact localization of the placenta, and we should always anticipate the poorly formed and vascular lower segment. When the placenta comes at the incision site, we have to access the membranes by insinuating the fingers in between the placenta and the uterine wall, and then rupture the membranes to access the fetus. We are in some cases we have to incise the placenta for rapid transplacental access and delivery of the baby. Delivery may be complicated by the floating head, and one should always prepare for the instrumental. One should always prepare for the instrumental vaginal delivery in cases of the placenta previa or low-lying placenta. As you can see here, the placenta is low-lying. Fingers were insinuated between the uterine wall and the placenta. And of course, the breech presentation was there, as it is common in cases of the placenta previa, and the breech extraction was performed. The next most common injury is the vascular injury, which is very common, that injury to the uterine artery. One simple measure, that is green armatage forceps or the Ellis forceps even can be used for the just to locate the injury, and we should tie with the vital number 1. Then next common difficulty is the extension during cesarean section, which is very common, and if again it can be done repaired with the vital number 1 with intermittent sutures. Intermittent sutures gives a strength, and there will be no issue of cut through of the tissues. Nowadays, patients also demand, and patients, our Google patients also demand for the natural delivery in cesarean section, and it is very there are very advantages of the natural delivery in cesarean section. Here, the baby's head is just delivered out, and after the delivery of the head, we have to take a pause for about 1 minute, means 1 to 2 minutes. Naturally, with uterine forces and uterine contraction, the anterior shoulder is delivered. But in these cases, we need patience, because in cesarean section, we are in very hurry to remove, extract the baby. You can hear the cry of the baby. Look, now the anterior shoulder is delivered. Interesting. General delivery. A lot of patience is required in this case. Yes, without any traction, the baby is delivered. completely.
Oh,
And baby is also. So how to optimize for complications in any cesarean section? Every institute have its standard operating procedures. One should always strive for the quality, equity, and dignity of the patients. And the take-home message is you should be. It is a learning, unlearning, and relearning of the any procedure. You should be safe. Be sure of what you are doing. Be swift in your surgery. You should be sound in your clinical and surgical skills. You should do surgery relentlessly and bloodlessly. An obstetrician should always have lady's fingers, lion's hearts, and eagle's eyes, and dexterity, of course, a good hand. The every effort should be made to provide cesarean section to women rather than striving to a specific rate of the cesarean section. All these videos are available on Gadappa Sir's YouTube channel, so you can always go through it. Very thank you.
wow, what a presentation, Dr. Swati. We witnessed Dr. Gadappa sir's videos, excellent videos, and I remember how he had given a very nice oration in amongst Nasik, and he got a standing ovation for placenta accreta spectrum. And this was a wonderful experience we all had. The concept of natural delivery in C-section is new to me also, and it is really wonderful. Excellent, excellent videos. Really mesmerized by your presentation. Thank you so much. Over to you, Chairperson.
I hope that
Yeah, Vaishali, please unmute yourself.
Hello, am I audible, ma'am?
Yes, ma'am.
Yes.
Good evening, all. First of all, thank you, Dr. Varsha Baste, ma'am, Dr. Sudesh Doshi, sir, and Dr. Sunita Khedkar for giving me the opportunity to chair the session. Every difficult cesarean section is challenging and different for each and every gynecologist. Dr. Swati Badge, ma'am, have explained each and every point stepwise and very systematically. That is right from abdominal incision till the delivery of baby by instrumentation, by natural method and all. It was really useful in our day-to-day practice. Thank you for excellent session, ma'am. Thank you very much.
Thank you.
Thank you,
Really,
Vaishali.
I'm really happy that all the speakers are so excellent in their presentation, and they really invoked interest in the obstetrician mind, how to deal with complicated patient and how to deal with labor emergencies. It was really wonderful talk by both the speakers. I'm really happy and thankful to them. Over to you, Dr. Swati.
Thank you, madam.
Thank you
I'm
so
very much thankful to the organizers for giving me the opportunity to share this mesmerizing presentation. I'm thankful to all the organizers. Thank you very much.
Thank you, Baste, ma'am.
Thank you,
Thank you,
Vaishali.
Vaishali,
Dr. Smita.
for your inputs. Now we'll move ahead to the third session. To chair the session, we'd like to invite Dr. Prasad Magar sir and Dr. Krishna Pawar sir. Dr. Prasad Magar sir is working as consultant gynecologist. He is from Parbhani, Maharashtra. He has special interest in bad obstetric history, medical disorders in pregnancy, infertility, and high-risk obstetrics. He is president of Parbhani Obstetrics and Gynec Society since 2020. Welcome, sir. To chair the session, we will like to invite Dr. Krishna Pawar, sir. He is secretary of Parbhani OBGYN Society, past secretary of Parbhani OBGYN Society, consultant at Ashok Hospital, Parbhani. Welcome, sir. We will like to invite the chairpersons to invite our next speaker, Dr. MC Patel, sir, and kindly introduce him.
Welcome, Dr. MC Patel, sir. I call him Bhishmacharya of Foxy. He gives nice advice, support, guidance, and whatnot. Always there to help us. Thank you, sir, for being here. And we are really waiting for your talk, how to tackle legally for such legal labor emergency cases.
So, should I share my screen?
Just a minute, sir. The chairperson will read your CV, na?
Okay.
Prasad, sir.
Monica for me. Prasad, sir, आहेत का?
Krishna Pawar, sir.
They were there.
Yes, I think he is left.
I think Monica, can you please read Dr. Premji Patel's CV? Dr. Monica, if you can do it, honors, otherwise I will read it. Okay, and it's a privilege for me to introduce our next speaker, Dr. MC Patel, sir. He's a consultant obstetrician, gynecologist, and medical legal counselor. Vice President FOXI 2018, Organizing Secretary of AICOG 2017, Chairperson Ethics and Medical Legal Committee FOXI in 2011-13, Honorary Joint Secretary State Organization of Gynecology and Obstetrician of Gujarat 19 to 22, Honorary Secretary State Organization of Gynecology and Obstetrician of Gujarat for 22-24, also organizing chairperson of MMCon for 2018, honorary member, National Inspection and Monitoring Committee, PCPNDT Act, Government of India 2015, honorary member, State Supervisory Board, PCPNDT Committee, Gujarat State 2005-2009, President Ahmedabad OBGYN Society in 2010, honorary member, National Managing Body, Indian Red Cross Society Headquarter for 2019-22, National President, National Medical Organizations for 16 to 18, President IMA Ahmedabad branch for 2007, honorary surgeon, Indian Red Cross, I Bank, collected more than 1,000 pairs. Wow. Organizing chairperson, Vivekanand NMO Conference 2013, President Lions Club, Gatlodia, Ahmedabad, 1997. So with this brief introduction, may I introduce Dr. MC Patel, sir, and he is going to talk on legal issues in cesarean section or instrumental deliveries. Over to you, Dr. MC Patel, sir. We are really honored with your presence, because these legalities we have to tackle very well if at all they occur during instrumental deliveries or cesarean section. Over to you, Dr. Patel, sir.
Thank you, Varsha, for kind words, and thank you for inviting me to share views about my views about the subject. So my video is not working, so I may not be seen, but hopefully I should be audible.
Yes, sir,
Thank
you're
you,
audible.
sir, for
And my screen is
thank you,
seen.
sir, for chipping in
Yes.
at the last moment, sir. And thank you, Prasad, sir, for joining in. I can see him right now, sir, ma'am.
So is it full screen?
Yes, sir. We can see your screen, sir.
Yes, we can see.
To the subject. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Varsha Batsey in particular for inviting me to share my views about the subject. Usually, I start any of my talk with this question: is it worth discussing as far as legal issues in difficult cesarean section is concerned? If it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and we gynecologists rank first as far as this medical legal problems are concerned. And as statistic goes, 80% of the total cases related to complication to OBGYN, it is related to obstetrics. And out of those obstetrics, 80% are related to cesarean section complication. So it is a very big area as far as litigation is concerned. So legal issues in difficult cesarean section, let us see where we end up into litigation. If it is a case of previous LSCS, polyhydramnios, cord prolapse, oligohydramnios, high floating head, multiple pregnancy, placenta previa, adherent placenta, whether it is accreta or percreta, and as far as fetal part is concerned, abnormal presentation, hand prolapse, fetal distress, or meconium. So these are the areas when we are dealing with any cesarean section case. And if it is added with this complication, then our responsibility becomes manifold, and it may end up into a bad outcome in few of the cases, end up into litigation. So which are the areas for litigation in management of difficult cesarean section? So many times in this type of situation, face the litigation and pay compensation, because there could be some problem in diagnosis. It is delayed diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, or wrong diagnosis, and we may end up into litigation. As far as complications are concerned, surgical complication of cesarean itself, or any high risk factors which is added, and it may lead to complication, and ultimately it may lead to bad outcome and litigation. As far as surgical part is concerned, trauma, injury, hemorrhage, possibility of infection, complication of anesthesia, these are the areas as far as litigation is concerned. Injury to surrounding structure. In previous talk also, one of the speaker has mentioned this also. So whether injury to vessels, injury to ureter, urinary bladder, or bowel, and you may end up into litigation in this type of situation. Many a time, this is also one more allegation, unnecessary investigation, because when we are dealing with any high risk factor, and if it is a planned cesarean section or emergency cesarean section, we have to go for so many investigation, and it could be one more area as far as litigation is concerned. No proper consent, no proper counseling, and no proper consent is also one more area for litigation. Staff not qualified, infrastructure issues, emergency services not rendered properly. It is also one more area. Communication failure, not properly communicated, delayed in transfer. If at all we have to transfer patient to higher center, and if it is delayed, then it is one more area as far as litigation is concerned. Complications, morbidity, fetal and or maternal, and in few of the cases, mortality, fetal and or maternal. Overcharging, because in this type of situation, when we are dealing with a complicated cases, tremendous expense against unexpected result is one more area for litigation. Asked for medical record and not provided, because we are under obligation to provide record within 72 hours as per MCI guideline, and within 5 working days as per newer NMC guideline. And in very recently case happened in decided in state of Gujarat. A case was, of course, it was preterm delivery, and ultimately baby went with retinopathy, and baby went blind. But baby was admitted for 42 days in NICU, and after 42 days, baby was discharged. But she was not, I mean, the parents were not advised to go for ophthalmic opinion, and ultimately baby went blind. It was the story. So for that, compensation of 69 lakhs was awarded. But patient, I mean relative of patient, had asked medical record from the gynecologist and that hospital, and they didn't produce those records. So above this compensation awarded, rupees 75,000 were awarded merely on the ground that medical records were not provided to the patient. So we cannot afford that also. So whenever asked by the patient or eligible relative of patient, we are under obligation to provide record. Of course, it is a property of hospital, but patient may demand a record of treatment given to her. Failure of patient to comply with scheduled follow-up. It is one more area as far as litigation is concerned. When you have dealt with a complicated cesarean section case, and we have instructed patient as far as follow-up part is concerned, and many a time patient fails to comply, and in this type of situation, it becomes a good defense in our favor, because it becomes a contributory negligence on part of patient. But in this, we should have very well explained at the time of discharge. So post-operative counseling is equally important in this type of cases. So what to do and how to prevent all this situation not to end up into litigation? So practice foreseeability, that is anticipation, good communication, valid consent, and proper documentation, and you will simply sail through. So court and law expect from us foreseeability or anticipation of certain complication, and we should be readily available to deal with that complication with any other procedure or intensive care. Say, for example, if it is a case of with history of previous two LSCS, and this time if it is a case of central placenta previa, and if you are going to go for cesarean section, naturally one should anticipate that she may end up into a PPH, she may require blood transfusion, she may require even obstetric hysterectomy also. So in this type of situation, if we have anticipated and if we are readily available to deal with situation accordingly, then it becomes a good defense in our favor. But in all those conditions, proper counseling is very much required, because at the time of counseling, usually we start like this. What is the complaint? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So at the time of counseling, we are under obligation to explain all the alternative modality of treatment we are offering to the patient, with possibility of morbidity, with probable expense, with possibility of mortality in few of the cases, probable prognosis, all the probable complications, possibility of blood transfusion, risk involved. We have to explain everything. We have to explain need of NICU care and outcome of baby at the time of counseling in this type of situation. But whatever we explain, it should be in a very simple language, and no much medical jargon should be used, and no rosy picture about result, no tall claim about result, because in eye of law, when you claim to be master, you are supposed to be master. And in any of our result in our obstetric practice, particularly cesarean section, when we are dealing with some complicated issues during pregnancy, then we consider result like Aishwarya Rai, but it may turn like this anytime. So no tall claim, no rosy picture in this type of situation. So proper communication and proper documentation. And when you take signature on consent paper, it becomes a documentation of your communication. And in this famous case of G. Jaypal Reddy, National Commission has very specifically mentioned that consent is not mere piece of paper on which patient or his relative has to sign, but it is a very important document of your communication, of your counseling. So whichever you have counseled to the patient, each and every point should be mentioned in consent paper, and then patient and patient party has to sign. So when patient signs the document, it becomes a document of your communication. So whatever you have communicated to the patient, it becomes documented with signature of patient. And in this famous case of Samira Kohli versus Prabha Manchanda, in this very case, it was mentioned, it is more than just sign here. And in this case, it was decided that what is the valid consent at the time of cesarean section or any procedure or any surgery, what is the valid consent? So which are the criteria for any consent to be valid? Who can give consent is the one more correct criteria, that is capacity or competence for giving consent. Any adult patient who is mentally sound can only give consent on her behalf. I have observed in my medical legal practice, so many of our friends have a habit to take signature of relative and not patient. You cannot afford, if at all you are facing litigation, if patient is adult, if patient is mentally sound, only and only patient can sign consent paper on her behalf. Nobody else can sign document on her behalf. If patient is minor, if patient is mentally challenged, then consent of guardian is required. But in this type of situation, if patient is minor and if it is unbooked patient and has come very first time and cesarean section is required, of course you have to go with cesarean section if it is indicated, but you will have to inform police because it becomes a case of POXO in this type of situation. If it is an emergency, if it is dial emergency to save life of patient, if it is immediate necessary to deal with cesarean section to save life of patient, no consent is required. But you will have to prove that it was dial emergency, and you can prove it by your proper documentation. It should be voluntary, it should be free, signed by patient or guardian as per the case maybe, and others are only witnesses. It should be informed one. Are your patient properly informed? Is one more important question asked on part of prosecution at the time of litigation. So patient should have knowledge about nature of treatment. Say for example, cesarean section. Patient should have knowledge about cesarean section, all with all its benefits and side effects. No fraud, no coercion, no false promise. And does consent required for blood transfusion? So if at all we have planned to go with blood transfusion, then yes, because in this case, the Honorable National Commission has very specifically mentioned that surgery involves risk and blood transfusion involves additional risk, so separate consent for blood transfusion is also required. Cesarean section with myomectomy. Many a time we have to go for this. If myoma is on the way to deliver baby and you have not taken consent for myomectomy, then also you can very well go with myomectomy and deliver baby. But if it is not on the way of delivery and prior consent is not taken, then you cannot go for myomectomy with cesarean section. Lower segment cesarean section with female sterilization operation, because many a time patient is willing to go for female sterilization operation at the time of cesarean section. So many a time this question is asked, can or should we do cesarean sterilization operation with cesarean section? Can, so yes, as per the guideline of government, and no as per one of the case decided in Supreme Court. Being a national program, tubectomy death is an issue discussed in Parliament and doctor becomes a soft target, and death cases may be breaking news for media. Even if death is related to complication of cesarean section, but if sterilization operation is done, then there will be special inquiry. So many of our friends are afraid to go with sterilization operation and cesarean section, but there is no law that you cannot go for sterilization operation. You can very well go with sterilization operation at the time of cesarean section, because there are guidelines on part of central government, and in respective state there are guidelines on part of states also. So if there is guideline on part of central government and state government that sterilization operation can be done with cesarean section, you can very well go with cesarean section. One more area, cesarean section on demand. Many a time for date, for day, or for time, cesarean section could be on demand. If patient is major, if patient is mentally sound, patient may demand, and we may comply with the demand of patient. There is no hitch as far as law part is concerned. But you have not to remember all these things. You have to simply visit Foxy website, and on Foxy website, uniform consents are available. Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. M.C. Patel from Ahmedabad, we three medical legal experts had prepared consent when Dr. Alpesh Gandhi was Foxy president. And we have prepared almost 30 different consents. And now I am happy to announce now it is available in Marathi also. All those 30 consents are translated in Marathi, and thanks goes to Nasik OBGYN Society and Dr. Gauri, president of Nasik in particular. They had taken a very important task of translating all those consents. They had sent to me all this translated in Marathi. I went through and we have finalized.
Yes.
During AMOX, it was given to so many of the delegates of AMOX. So it is available on Foxy website in English, and it is available with Marathi also. Whosoever is interested to have a soft copy, either of English or in Marathi, it is available with me also. So anybody can contact me for those consent. So in those consent, I do not go into detail for other consent, but today's topic is cesarean section. So I would like to mention very quickly, we have prepared those consent in two parts. Part one is information about surgery. Say for example, name of procedure, that is cesarean section. Meaning, what is the meaning of cesarean section? We have mentioned in a very simple language, whether it is emergency cesarean section, whether it is planned cesarean section, whether it is lower segment cesarean section. We have mentioned everything in simple language. Purpose or indication, we have given list. You have to simply mark the indication in your patient, and if you have to go with one more indication, so at the end you can add indication also. Description of procedure, how cesarean section is done, elective or emergency, we have mentioned in a very simple language. Description of procedure, so benefit of procedure, so how it is beneficial to the baby if we go with cesarean section, and to mother we have mentioned that also. Alternatives, if patient is not willing to go for cesarean section, then which are the alternative? Naturally we have to go for vaginal delivery, but with added risk. Consequences of refusal of procedure, if patient is not willing to go for cesarean section and patient is not willing to go for consent, then in this type of situation we have to go with negative consent. So we have to take consent from a patient that we had been explained that emergency cesarean section is needed, but we are not willing to give consent. Many a time patient is not ready to give negative consent also. So in this type of situation, you can take signature of any co-patient or any visitor of hospital, and they may sign that before us everything was explained to the patient and cesarean section was required and patient was not ready to give consent. So if we have taken this type of negative consent, then it becomes good defense in court of law if at all we have to face any complication. Outline of substantial risk involved in cesarean section when we are dealing with certain odd situation. So we have mentioned everything in this subheading of outline of substantial risk. Risk of anesthesia, excessive bleeding, blood accumulation, possibility of infection, injury to surrounding structure. Every individual has a different way to cope up as far as scar formation is concerned, in future hernia formation, or in future placenta adherence spectrum. So we have mentioned each and every point as far as cesarean part is concerned. Very rare condition, that is allergic reaction to any drug or drug of anesthesia, we have mentioned that also. Future consequences with adherent placenta or scar ectopic pregnancy in future, possibility of that also we have mentioned in that consent. Outcome of baby with neonatal morbidity, if at all we are suspecting, we have mentioned everything there in that consent. And part 2 is undertaking. So whatever we have explained in part 1, patient will go in undertaking in part 2. But in this undertaking, this section 3 is very much important. We have very specifically mentioned that I understand that during course of surgery, doctor may find other unanticipated unhealthy condition that may need specific action, procedure, surgery, and anesthesia. If doctor feels that it will be beneficial to treat such condition while performing proposed surgery, and if I am not in a mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. and Mrs. So-and-so who is waiting outside operation theater. I authorize above mentioned person to give proxy consent on my behalf. So if at all any emergency situation happens at the time of cesarean section and prior consent is not taken to extend the scope of consent given by patient, and if patient has given this type of consent, we may discuss with the relative and we may proceed accordingly. We have mentioned one more area. If patient has given consent like this, that in order to save life, it may even be necessary to do additional surgery or procedure or prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if the need be. If patient has mentioned this type of sentences in consent paper, then you are at liberty to take decision in given situation to save life of patient. At the end of consent, signature or thumb impression, whichever the case may be, but in case of thumb impression, it should be attested by relative who knows the patient. But in this situation, relative should be major and mentally sound. So two witnesses, one on part of on behalf of patient and one in favor of hospital, we will have to go with 2 witnesses, and signature of doctor is also very much required in consent paper. You will ask why signature of doctor is required. When any patient enters in your consulting room and once you accept her to treat, it becomes a contract or implied contract between patient and yourself in eye of law. So you are offering your expert services and patient pays for that, or patient promises to pay for that. Under Indian Contract Act, unless all the party involved in the contract signs the document is not complete. So to make this consent a complete document in eye of law, signature of doctor is very much required. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have, if you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way, because in spite of all these occupational and professional hazards, our journey to serve human and mankind is always on and on. So I complete my talk with this. If you want to sleep like this, take tender care of your patient, comply with the provision of law, all the statutory provisions, pray your Almighty God before going to sleep, and keep my visiting card below your pillow. And this gentleman is going upstairs, and some people are coming downstairs and they want to help this gentleman. So very small video, how they help this gentleman. So as if the gentleman wanted to go upstairs, and these people wanted to help him. So even if you want to help somebody, then also proper consent is very much required. So with regards, salute to all the organizers and particularly Dr. Varsha Batse. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Thank you very much, sir.
Welcome, sir.
So much, Dr. Patel, sir, for your excellent, exhaustive talk and eye-opener for us, how the consent is very, very important during cesarean section or any other operation. And you have given the reasoning why each and every point is important and what is it in about consent. So every time I listen to you, something new take-home message always is there. And wonderfully, you have really covered all the FOXY under your umbrella of legal advice, and we feel protected under your advice. Thank you so much, Dr. Prasad Magar. Thank you so much for chairing the session. Over to you, Dr.
Now let's move ahead to our last session, that is panel discussion on nightmares in labor room. To moderate the session, two excellent panelists, Dr. Varsha Baste ma'am and Dr. Kalyan Baramde sir. Varsha Baste ma'am, we all know her. She is senior gynecologist and infertility specialist in Nashik since last 30 years, director of Baste Maternity Hospital and Pushpa Fertility Center.
No need to
Welcome,
again read my system. Yeah, thank you.
Okay, well, then our second moderator is Dr. Kalyan Varamde sir. Sir is a consultant infertility specialist and gynecologist, director of Varamde Hospital, Latur. He is chairperson of Public Awareness Committee FOXY 2019 to 22, joint secretary of IAGE. He is convener of Mission Save the Uterus FOXY 2019 to 22, executive member of MSR Chairperson of Infertility Committee AMOX, and President of IMA Latur. Welcome, sir. I'll request
Okay.
Kalyan sir and Varsha ma'am to
Okay,
conduct the panel.
hello, dear all esteemed faculties, as a panelist, the doctor, first is Dr. Vaishali Surase from Aurangabad. Welcome, Dr. Vaishali.
Thank you so much, ma'am. Thank you.
Next is the Dr. Anil Kayande sir, who is from Amravati. Welcome, sir, for being a panelist. Dr. Anuradha Garad, beautiful girl from past president of Usmanabad. Welcome, Dr. Anuradha. Then Dr. Smita Kulkarni, she is the infertility specialist from well-known person, ART specialist from Jalna. Welcome, Dr. Smita.
Yes, thank you,
Nice to
madam.
meet you here. Dr. Rachana Jaju, you are most welcome. You are the face of young AMOGs, I will say. Latur, you have really worked very hard during the conference in AMOGs conference, Aurangabad.
Thank you, ma'am. Thank you.
Yeah. And Dr. Purnima Yande, welcome, madam, from Bid. And she is going to be the esteemed last panelist for our this panel discussion. So I will do this. Let me share my screen. Tanmay? Presentation. No. Labor emergencies. Yes. Yeah, can you see the screen?
Yeah. Yes, madam.
Yeah, just now. So welcome all the panelists. We will have to go little quickly because the time is quite short for us. Our esteemed panelists, I have already introduced them all. So let us go for case number 1. She is gravida 2 para 1 into labor and post dated by 7 days. First pregnancy, full-term instrumental delivery, weight was around 2.9 kg. This pregnancy supervised registered outside. The patient is in labor at another hospital but referred for slow progress of labor and big size baby. On admission, uterus full-term and contractions mild, 6 centimeter dilated, 90% effacement, station was 0, pelvis adequate. What complication here one can expect? Dr. Vaishali Gaikwad.
Good evening, ma'am. Thank you for making us a part of the panel. Ma'am, first of all, history is very important in each and every case, but especially when a case is referred from another hospital, it is very necessary to take a proper history of the patient regarding whether she was in spontaneous labor or whether any induction was done since she is post-dated, then since how long she had been in labor. Did she had any history of PPROM, or what is the exact this thing why she is referred to our hospital? We should always note that. Then while managing the case after the history, it is always this thing that the patient must have been exhausted. She must be in some electrolyte, this thing. So we have to give her some ringer lactate. We should always, here I think the FHS are not mentioned. So we should see whether how are the fetal heart rate, and accordingly we should decide about the management. Ma'am, seeing the vitals of this patient and the vitals of the baby and properly examining the patient, we should start managing her.
Very good. Dr. Anil Kande, after 3 hours, the cervix was fully dilated. Head descended down, crowning is seen, episiotomy is given, head delivered, but baby is not coming out. So what might be the cause according to you, Dr. Anil? Dr. Anil, are you there? Or I asked Dr. Smita Kulkarni.
Yeah, madam. Such kind of emergencies are really nightmares in labor room. Because what happens when the baby's head is delivered and then if further delivery is not possible, that means the baby, we are facing a case of shoulder dystocia. Usually, impacted shoulder. And such kind of difficulties actually should be anticipated, but every time it may not happen. Like in this case, there is one very leading thing, that is a post-dated pregnancy. The first delivery is a big size baby, but still sometimes a shoulder dystocia may not be anticipated. And if you see a case of head impacted, first and the foremost thing is you should inform other and call for help, because you should not be single-handed. You should call others, inform others. These are like we have some guidelines as alarm, that you please inform others, call for help. And then first and most easiest thing is the release legs of the patients. If the patient is kept in a delivery position, that is a MacRoberts position, that you release the legs and keep folded on chest to knee position, that really widens out the pelvis. And another very, very important thing is try to disimpact the shoulder, that is, you change the axis. And most of the time, these are some other maneuvers where we disimpact. And usually such cases are rare, but once, I think in the beginning, Mandakini madam had mentioned, and I had such an incidence in my residency days, that we had a case of impacted shoulder and we literally fell down with the baby on floor. So such things do happen, madam, because we are in so much tension when the head is delivered and you cannot deliver further. So you must maintain calm, see to it that you first release the posterior shoulder, then anterior shoulder. And while in such places, what happens, because the head has come out and because the abgar will go down, the baby will not cry. So you really try to, you automatically become upset.
Yeah. Okay. Then Dr. Rachana, will you diagnose this? Can you any means of diagnosis this antepartum by sonography or by measurements of fetal parts or fetal weight estimation method? What do you think? What are the predisposing factor? What is the incidence, or how to diagnosis in antepartum that the baby will be having shoulder dystocia? Is there any guidelines, or we have to judge it clinically?
Ma'am, incidence is 0.5 to 4%, and we cannot anticipate shoulder dystocia. It can commonly be seen in a normal delivery also, but in maternal cases, the predisposing factors are obesity, multipara, she's having gestational diabetes mellitus, prior history of instrumentation. These are the predisposing factors in mother, and in fetus, it can be fetal macrosomia. And definitely on USG, we can diagnose whether we can anticipate a shoulder dystocia if a fetus is weighing say 4 kg or more than 4.5 kg, then we should anticipate. But as I said earlier, it can also happen in a normal baby as well.
Okay, very good. So this is the procedure, what already Dr. Kulkarni has told us, presentation of the head, then anterior, we have to compress give pressure, and the shoulder, the delivery of the anterior shoulder, then delivery of the posterior shoulder, and delivery of the lower body and umbilical cord. So Dr. Anuradha Garad, can you tell us about maternal complication and fetal complication of shoulder dystocia?
The most important maternal complication of shoulder dystocia, there will be the injuries to the mother during the delivery. There can be anal sphincteric injury to the mother. As far as the baby is concerned, the most trivial complication is a brachial plexus injury. There can be the most common is the Erb's paralysis. Clump case is very less common. Usually, most of the brachial plexus injuries will be recovered by 12 months, but 5% to 10% will remain, and that is the most common cause of litigation in these cases. There can be the humerus, there can be the fractures, clavicular or the humerus fracture. The baby, because there will be a delay in the delivery of the baby, there can be a hypoxic injury to the baby, and there can be hypoxic ischemic encephalopathy. What else?
Yeah, so the medical importance is also very important. So what the things to do? Rachana, can you highlight the medical importance about what the things to do? Do you go for fetal skull pH for recording or documentation?
We should ideally record it, madam, the fetal skull pH, but we are in so much of rush that it usually doesn't happen. And if we have met with some, unfortunately, some problem with the baby or mother, then it should be informed to the relatives as well.
So these are the maternal complication, pre-complications. Already Anuradha has told, and a risk factor for shoulder dystocia, maternal and fetal. Maternal are abnormal pelvic anatomy, gestational diabetes, postdated pregnancy, previous shoulder dystocia, short stature, and fetal suspected macrosomia. Labor-related assisted vaginal delivery, forceps or vacuum, prolonged active phase of first stage of labor or prolonged second stage of labor. So the history, antepartum factors and interpartum factors are also very, very important. So management of shoulder dystocia is alarmer. That is, ask for help and let the hyperflexed, then apply suprapubic pressure that Dr. Kulkarni Smita already told us, and anterior shoulder impaction, disimpaction, release posterior arm, maneuver of force, episiotomy, roll onto all fours if it is not possible, and then again try again all these things. So this is the algorithm of doing this delivery of dystocia, shoulder dystocia, by extended lithotomy position, and then thigh to abdomen, that is the maneuver, suprapubic pressure, consider episiotomy, then deliver posterior arm and internal rotational maneuvers, inform consultant and obstetrician anesthesia. If not baby delivered, then all four position, or repeat all above again. And if not, then finally you can go for a clavicle cladectomy or symphysiectomy also to deliver the baby. So let us see the case 2. Is Dr. Kalyan there, or I will take the case? Okay, I think he is not there. So second case is a 27-year-old gravida 2, para 1. She is in labor. First pregnancy is Caesarean section for breech 3 years back. Post-operative period was uneventful. Now supervised, registered full-term patient. 38 weeks as per first ultrasound, vertex presentation, baby weight expected 2.8 kg. What is the plan of management in this patient? So I would like to ask Dr. Purnima Yande, what assessment and what gestational age you will do the assessment of these patients?
Madam, this
Dr.
age
Purnima?
is the right 38 weeks is the right time.
Yes.
Am I audible?
Yes.
Yes, madam.
Yes, madam. Yes, you are.
This at this gestational age is the right time to sit with the patient and decide first what is to be done.
Yes.
Whether the patient wants to go for a cesarean section elective or she wants a vaginal delivery, and document it properly. Document it on our notes as well as on the patient's case paper. If the patient wants to go for a vaginal delivery, their MRCOG guidelines say that there are 60% chances that there is a successful vaginal delivery. And now when everyone is asking for reducing vaginal cesarean section rates, VBAC is an option, but it has to be done with thorough counseling of the patient. And once the patient says, yes, we can try for a vaginal delivery, we have to assess for the pelvis, because it should not be the end of the day she has a contracted pelvis and you are putting her in labor. Then nowadays, even the scar thickness, our radiologist or even us, we can see the scar. If there are studies which say that if the scar thickness is less than 3 or 3.5, it gives a high incidence of uterine rupture. So thus patients have to be counseled very well for earlier for the progress of labor.
Excellent. So the role of CTG So what is important according to you, Dr. Vaishali Gaikwad,
Yes, ma'am.
to manage such a patient? Is the role of CT is important, partogram, induction, method of augmentation, timing, monitoring, wireless CT is also available. So can we, one product, you can tell me, otherwise you can tell, can one predict scar decisions?
Yes, ma'am. If the patient, usually if she has gone into spontaneous labor, one can always give her a trial of VBAC. I personally would not induce or augment her, but if she's already in labor, then we can always support her by monitoring her. And if she wants, I mean, if the consent is there and she knows the complications related to VBAC, like scar dehiscence, scar rupture, fetal distress, so in that case, we can properly monitor her and go ahead with VBAC. In that case, we have to monitor her vitals, ma'am. We should be careful about her tachycardia, then hypotension, and hematuria. In some cases, also it's seen. Then we have to monitor the baby if the baby has tachycardia or if it is going into distress through lessening of the heartbeats of the baby also.
Anybody can tell us what is crash LSS, Dr. Smita?
Crash analysis is, madam, when you have to take an emergency decision, like a patient's of VBAC, where you have to immediately take a decision where there is a scar dehiscence expected, then you have to take crash analysis decision.
So what are the signs of uterine rupture, Rachana?
Madam, there will be fetal tachycardia first and foremost, and then maternal tachycardia as well. Severe pain in abdomen.
Okay. And when will you go for obstetric hysterectomy, Dr. Rachana, sorry, Dr. Anuradha?
Obstetric hysterectomy, madam, depends. If you have seen a scar rupture, which you are not able to suture, if there is extension of the, if there is a rupture and if there is extension, there is extensive broad ligament hematomas that we are not able to suture, or a patient has gone in the PPH, it can be atonic or a traumatic. If such situation arises, then only we will go for obstetric hysterectomy. Otherwise, I think even in a scar rupture, we can suture, and maybe few cases it will be needed.
Can you little bit highlight about positive prediction, negative prediction, Dr. Purnima Yande?
VBAC, madam, there is a VBAC score. That is how positive, whether the patient can deliver. Then there are certain guidelines given. Spontaneous patient going in spontaneous labor is one of the good predictive marker. Or if there is the patient's BMI high, then there is a poor marker. Again, if there is a previous spontaneous vaginal birth, there are 4-5 indications, and earlier indication for cesarean section, whether it is a repeat indication of cesarean section, whether it was first CPD or it was for a malpresentation or any other indication. So in certain cases, we have if the score is good, then VBAC has a good rate. If the score is bad, then it is better not to go for a VBAC and plan the patient for cesarean section.
So nice, Dr. Purnima Yande. You are coming from BID, but you are giving such a nice guidelines, I will say, how to do VBAC and all. Let us move to case 3. 32-year third gravida, two full-term normal deliveries. One is 6 years, 3 years, another child is 3 years. No history of any complication in the previous pregnancies. She had full-term normal deliveries, came with 9-month amenorrhea, pain in abdomen, uterus full-term, vertex presentation, mild contractions revealed, per vaginally, cervix was 6 centimeter dilated, 60% effaced, station was 0, pelvis was adequate, argumentation by oxytocin was done, delivered by staff, baby cried immediately, but mother suddenly collapsed. What will be the probable cause? Can Dr. Anil Kande, is he there? No. Okay, Smita, you can take over.
Yeah. So the first part of the case appears that it has been like a smooth delivery and looks like so-called normal delivery, but such complications do happen even after normal delivery. And most important is embolism, and second one is if there is uterine inversion or if the while placenta is, because we have mentioned the baby is delivered if the placenta is not delivered. Sometimes if the placenta has not delivered, or if the staff has, there is an undue traction given, there can be uterine inversion, which leads to a sudden collapse, and such kind of emergencies has to be managed very rapidly. Sometimes there can be uterine ruptures also. So we have to assess what has happened, see the vitals, and first take care of vitals, arrange for blood, see like what has happened, whether she needs monitoring, and if there is now whatever obstetric cause, if there is inversion, whether we can do a replacement, and if there is embolism, then we need all even involve other faculties in management of it.
Yes. So Dr. Vaishali Gaikwad, so what are the predisposing factors? But generally we have to take the consent, because here this amniotic fluid embolism can occur to normal patient also. So it is always important to take consent in normal delivery also. So what are the predisposing factors according to you, Dr. Vaishali Gaikwad? What is the immediate management, and in case of type inversion, what anesthesia would you prefer? Any other drugs, any operative procedure for inversion of uterus correction? Would you go for abdominal, vaginal, or combined approach? Dr. Vaishali?
If we see that there is some mass coming out for vagina, ma'am, and the placenta is not separated, in that case, it must be like the undue traction is given, as Dr. Smita said. And if staff delivers, usually it happens that they are in a hurry to remove the placenta. So that must have happened. Yes, ma'am. And in that case, ma'am, we should try to reposit the placenta as the uterus back as soon as possible. We can do this with a closed fist, and we should try to put the placenta and the uterus, the fundus of the uterus, totally back into place as soon as possible. If that is not happening, and if that is not happening, then we can always take the patient's consent for an emergency laparotomy. And ma'am, under anesthesia, we will have to replace the placenta and the uterus back, because in general anesthesia, the uterus relaxes and we can easily put it back.
Very good. So now, what are the complications of inversion, Dr. Anuradha?
Yes, I want to add one thing, that inversion is the condition in the obstetrics where we have to stop the oxytocin to relax the uterus when the patient is in collapse. This we have to remember. So diagnosis of inversion is very important because in the inversion, the shock is disproportionate with the bleeding which is occurring. The patient will be in the neurogenic shock, so we have to call for the help. We need an anesthetist to relax the uterus, and for re-inversion we need a good relaxation. The part of the uterus which has inverted last is to be reposited first. We have to repositate it in under good relaxation in a fist-like manner. Hydrostatic method we are not following. We are using it under anesthesia, and if we are not, and after repositing, we have to keep the hand in the uterus till it becomes hard, and that time we have to start the oxytocin again. And if we are not able to, we have to keep it for at least 5 to 10 minutes. The uterus becomes hard, and after that we have to release it, and we have to continue the oxytocin after that. Secondly, if we are not able to do it, then we have to go for an operative procedure under general anesthesia. If we are not able to,
yes, and you have to inform the patient recurrence chances are there for such cases for the next pregnancy. That is a written discharge card. You have to mention it. So let us take in the last case, because the time is up now. The fourth gravida, previous 3 full-term normal deliveries, 9 months of pregnancy. She came in labor with good contractions, uterus full term, vertex presentation, fetal heart regular, 5 centimeter dilated, 40% effacement, station 0, pelvis adequate, blood pressure 40/90, hemoglobin low less 48.5%, urine albumin trace, suddenly variations in fetal heart notice, and patient complaining of severe pain constant. So how to proceed in this case? Dr. Rachana Jaju. Is she there, Rachana?
Yes.
Would you like to take Dr. Purnima Yande?
Ma'am, I'm there.
Yeah, Rachna.
Yeah.
Ma'am.
Yeah.
You can tell.
Ma'am, she is multipara with blood pressure of 140 by 90, HB is showing 8.5 and complaints of severe pain. So and variations in fetal heart. So these all parameters are pointing towards maybe she could be suffering from an antepartum hemorrhage such as abruption.
Yes, very good. Because of the all these signs and symptoms, and we can catch it immediately. So, what are the causes of accidental hemorrhage, Dr. Purima Yande?
Sir, madam, in this case, first it will be because the patient has PIH, and secondly, she is a multipara. So these are the predisposing factors. And secondly, I mentioned anemia. So because of poor placentation, anemia, all these multiple factors, she might be having this APH at this present stage.
Yes. So the findings were uterus are tender, which is not variable, and what are the causes of accidental hemorrhage? Predisposing factor, and is sonography is needed in labor room? What investigation and CTG is? If it is really important, Dr. Smita, you can highlight on it.
Yeah, USG is very important because what happened more now it appears that it is not a revealed abruption. In case of revealed abruption, we can see sudden gush of bleeding, but when it is not a revealed abruption, sonographic diagnosis in labor room can really help us to locate if there is any clot. Then we have CTG monitoring, that is also important because variation in the heart rate can help us to decide what should be done, because like what is the timing, how much time we have to deliver, and what methods we can do, like deliver, or if there is a bigger clot, then we have to see her blood parameters also, because she appears to be a case of preeclampsia. So whether she can be augmented and delivered normally, or whether she needs any intervention, that can be decided with investigation.
Oh, very good. So, Dr. Purnima, can you tell us about the these management factors important in managing this type of case? Dilatation, effacement, fetal heart contraction, augmentation, caesarean. In which cases would you like to for her to go undergo?
This is when now what the patient, how far she has progressed in labor. Because if she's going to deliver fast, it is better to do a amniotomy, put a pitocin drip and deliver her. If not, and you feel that the fetal heart rate is variable or there are decelerations on the CTG, it is better to go for a fast cesarean section. Blood will be required in any case. At this present moment, it is better just our duty to save the baby, because abruption, if the FHS is variable, then you have to save the baby first. So the decision has to be on table, what is to be done. Blood loss, you have to estimate.
Dr. Rachana Jaju, would you like to go for replacement of blood, the products, blood loss estimation? How will you go for this page classification?
Blood loss is anticipated because once we deliver the baby, then we can also expect some part of postpartum hemorrhage also. So, and we also don't know how much of the blood has been lost, because it appears to be a concealed APH. So all blood parameters have to be reserved.
Yes, very good. And the risk factors for such patient, labor emergencies, that maternal and fetal vasopressia is less than 1%, but it is also very dire emergency.
Yeah. And
placental bleeding, 70% maternal placental bleeding is because of placenta previa or abruptia placenta. Unexplained are 25% or intermediate bleeding present, but source and site is not determined. Extra placental causes are 5% because of cervical polyps, CA cervix, varicose vein, and local trauma. So the risk factors, idiopathic, she might be, like Dr. Swati told, she might be a patient of preeclampsia, direct trauma, multiparity, advanced age. Dr. Purnima also informed us, added her inputs, uterine over-distension because of polyamnias or multiple pregnancies, sudden decompression of uterus after delivery of first baby, or hypertension, smoking, folic acid deficiency. These are the risk factors. So this is the algorithm of abruptia placenta. What should we do? For the panelists also already told us about revealed or concealed. For resuscitation, patient in labor. Dr. Yande also told us that ARM should be done and oxytocin should be started. Patient is not in labor more than 37 weeks. ARM oxytocin, according to Dr. Yande, that is correct. But if she is less than 37 weeks and bleeding has stopped, we can give for expectant management, try to continue pregnancy up to at least 37 weeks. And if she's the bleeding is continuous, ARM and oxytocin, and concealed blood transfusion, urine output, Dr. Swati and Dr. Jaju also told us we have to do fetal monitoring, blood transfusion, urine output is important. If not, ARM, oxytocin if needed, no response, oliguria, fetal distress, C-section, and in cases, hysterectomy. So thank you all the esteemed panelists for giving us the very nice guidelines and nice advice about tackling this labor emergencies. At the last, let me first, before stopping my slide share, I would like you all to see these. Mera chehra dekhna aur sikka marna. For the post of vice
Madam,
president.
you are so famous and known to everyone.
No, it's it's not that, but see, I'm going for the post of vice president Poxy West Zone. So please help me, guide me, support me, and I will stop my slide sharing.
Always, madam. Always.
Ma'am, best wishes from us.
Best wishes to you, ma'am.
Best wishes to you, ma'am. Thank you.
All the best, ma'am.
So over to
You are
you,
sure to
Doctor.
win.
Where is our MOC?
Sunita, she's there.
Sunita. Sunita. Yes, she's there.
That was excellent panel, ma'am. We are thankful to all the esteemed lecture speakers, chairpersons, moderators, and panelists. We are thankful for Shield Healthcare for all the technical help. Thank you, and we wish you all the best, Varsha Baste, ma'am.
Let me first congratulate all the panelists. I'm really fond of you all now because you really gave such nice, exuberant, and active, and so practical, thorough knowledge. Purnima Yende, madam, thank you so much coming from BID, and you gave such nice discussion. You took part in actively in this discussion.
You are my
Dr.
guide, madam.
Vaishali, Dr. Rachna Jaju, Dr. Smita, Dr. Anuradha, and all of you gave very nice inputs, and you look to be great obstetricians tackling the patients in labor emergencies. Like all you gave fantastic answers, and it was really wonderful panel discussion. I would like to thank all the chairpersons who graced the occasion. I would like to thank our chief guest, Dr. Pardeshi sir, the guest of honor, Dr. Madam Mandakini Meg madam, our Dr. National AMOX coordinator, convener, Dr. what is his name, Doshi sir, and all the panelists and all the speakers, fantastic, mesmerizing. Dr. MC Patel sir is still there. Dr. Vaishali Datta, Lalita madam, I can see all of them. Yeah, and it was really mesmerizing talks, take-home messages, and wonderful webinar. So many inputs, wastes, and how to apply, and so interesting videos. It was really wonderful and thorough knowledge, great scientific academia we all had. Thank you so much, Dr. Lalita Swami, also Dr. Vaishali Datal, Sunita, for being wonderful MOCs, Purnima. I'm really liking you like anything. Yende madam, Rachana Jaju is my favorite. Vaishali, Surase, Dr. Smita, you are my old friend, and Dr. Ananda Dagarat, beautiful girl from Osmanabad. Thank you so much for being here and your active participation. Thank you. We will meet again. Shabba khair. Good night. Thank you.
Good
Love
night.
you all.
Bye,
Last,
madam.
I
It was wonderful
thank
to meet
Dr.
you.
Sahitya Priya, Shield, always helping me since long. Thank you. Thank you so much.
Thank you.
Good night.
Thank you.
Thank you.